Hi guys, welcome to my channel Med Student Notes. In my first video, I am going to talk about jaundice in a way that you can correlate the pathophysiology with the lab findings of the different types of jaundice and some of the clinical features. So let's go right ahead. Now, jaundice is the yellowish discoloration of body tissues due to the deposition of bilirubin in it. Now, where does this bilirubin come from, and in what conditions, and how does it increase to a point where it's depositing in tissues of the body and making it yellow? First, we know that the normal life cycle of an RBC is about 120 days, right? So, when its 120 days are up, the RBC is going to go into a macrophage to end its life. In the macrophage, it's going to break down in such a way that heme is going to come out, and from heme we get biliverdin. From biliverdin is where comes the hero of the story, bilirubin. Now, bilirubin from the macrophage is transported to the liver with the help of albumin. It cannot go alone, and albumin is our friend that's just going to drop off bilirubin at the liver. When bilirubin reaches the liver, there's a very important enzyme called the UDP glucuronal transferase in the liver, and this is going to help conjugate the enzyme bilirubin. So, in the liver, we are going to get conjugated bilirubin. This is the normal process that I'm talking about. Then it is going to go into the bile, into the gallbladder, where it's going to be stored until it is needed in the GI system. So, it's going to go into the intestine, and eventually conjugated bilirubin with the help of bacteria in the intestine is going to break down into unconjugated bilirubin again. So now our normal unconjugated bilirubin is going to be turned into something called urobilinogen, again with the help of colonic bacteria. Now, some of this urobilinogen is going to go back into the bloodstream and go back to the liver, where it is going to take part in enterohepatic cycling, because it's gone from the enteric part, that is the intestines, back to the liver, right? And the rest of the urobilinogen is going to continue in the intestine and become stercobilinogen. Stercobilinogen is what imparts the brown color to feces. And some of it is going to go to the kidneys from the circulation, and here it is going to come out in the urine as urobilin. And the urobilin in urine is what is going to give you the yellow color of the urine. Now, conjugated bilirubin is also something that can dissolve in the urine. Conjugated bilirubin is water soluble. Unconjugated bilirubin, that means the bilirubin that is here before it reaches the liver, is not water soluble. So if you see bilirubin in the urine, in case, you have to realize that this is going to be conjugated bilirubin. Yes? And conjugated bilirubin can also impart increased yellow pigmentation or darkness to the urine. Now, we have gotten the normal part clear. This is not what is going to lead to jaundice. Let us now see what is going to lead to jaundice and what are the three types and how can we classify them. Now, we have spoken about what happens when the RBC dies and how that leads to the formation of bilirubin and so on. But what if there's an increase in the number of these RBCs? What if there is so much RBC breakdown happening, an increased amount of bilirubin? Right here. Now, in what conditions can this sort of RBC breakdown happen? It could be a hemolytic anemia, right? Now, hemolytic anemia could be something like thalassemia, sickle cell anemia, autoimmune hemolytic anemia. So now we have a lot of bilirubin here, but the amount of UDP glucuronal transferase in the liver is going to remain the same. The liver can't magically produce increased amount of UDP glucuronal transferase because there's increased bilirubin. It is going to produce as much as it normally can because that is its capacity. Normally, if, for example, we had some X amount of RBCs going into the some X amount of RBCs dying and some X amount of unconjugated bilirubin being produced. And to conjugate this X amount of bilirubin, we would have some X amount of UDP glucuronal transferase. But now, in this case, there could be like some 10x amount of bilirubin produced. Now, this is just a number to explain. Don't take the number too literally. We are not going to have 10x UDP glucuronal transferase. The liver is going to try to compensate by increasing its conjugating capacity and the enzyme, but it can do so only up to a certain extent. So there can be a little more than X, but not enough to cover all the bilirubin being produced. So we will be left with a lot of unconjugated bilirubin. Now the bilirubin that has been conjugated is going to go into the intestine. Our urobilinogen is going to be formed. It is going to circulate normally. We are going to have stercobilinogen, urobilinogen becoming urobilin. All this is going to happen. Enterohepatic cycling. All this is going to take place. But our only issue here is there is just a lot of unconjugated bilirubin. What will this cause? Hyperbilirubinemia. What will this hyperbilirubinemia cause? Jaundice. So, because this is happening, this condition is right before it even reaches the liver, we also call it prehepatic jaundice. It is also called hemolytic jaundice because of the reason that we've already discussed. So, what happens to serum bilirubin in this case? Total bilirubin obviously increases. What about conjugated bilirubin? The liver is going to conjugate as much as bilirubin as it can, that's it. So, we are going to produce a normal amount of conjugated bilirubin, yes, but the unconjugated bilirubin is going to be very, very high. Now, is there going to be bilirubin in the urine? No, because some normal amount of conjugated bilirubin can go into the urine, but it's not a significant amount. And because we have an increased amount of unconjugated bilirubin, and this is not water soluble, there's not going to be any increase in the urine bilirubin. So there's nothing significant here. What about serum urobilinogen? This is also going to be normal. Now, what about urine and stool? These are also going to be normal. So how will this patient clinically present? We're obviously going to see symptoms of hemolytic anemia, right? So they're going to have pallor, fatigue, dyspnea. And depending on the type of anemia, we could see symptoms related to that. Like, for example, if it is sickling, in periods of stress or hypoxia, they're going to experience sickle crisis, etc. But that's a whole another video. What happens to the enzymes, the liver enzymes? There's no defect in the liver, there's no defect in the bile duct. All of that is going to be fine. So we are going to have normal ALT, AST, and ALP. These things would be raised if there is a liver pathology, and this would be raised if there was a bile duct pathology. And this is all normal. So these are our lab findings of prehepatic jaundice. Serum LDH increases in hemolytic anemia. Now, what about hepatic jaundice? That means, what if there's something wrong with our liver itself? There could be conditions like viral hepatitis, alcoholic hepatitis, is getting severe and leading to some cirrhosis, cases like that. So, if there's a defect in the liver and everything up to this point is normal, there's a normal amount of RBC that is dying, there's the macrophage helping it break down, and there's a normal amount of unconjugated bilirubin reaching the liver. But there could be two things that could happen in this case. One is that the liver is going to conjugate the bilirubin properly, but there is a problem in letting the bilirubin go out because of distorted architecture. So there could be an increase in conjugated bilirubin. Or because the liver is so badly damaged, this enzyme also could not be functioning at its optimum, and that could increase the unconjugated bilirubin level as well, right? So here we are going to have a total rise in the serum bilirubin, Both conjugated and unconjugated bilirubin can be increased. There can be increased urine bilirubin present if the conjugated bilirubin increases to a point where it is so much an amount that it escapes into the plasma from the liver and it goes into the circulation and comes out in the urine. Because it is water soluble, conjugated bilirubin can be seen in the urine. So, urine bilirubin can be seen. Now, because there is damage in our liver, our normal functioning of the urobilinogen cycling back into the liver could also be damaged. So, the liver is not able to take this up properly, and so in this case, it is likely that the urobilinogen also increases. What about our urine and stool? The presentation of this would be variable depending on what is increasing, conjugated or unconjugated bilirubinemia. So let's just write down variable here. So in these cases, in hepatic, you have to check out which sort of bilirubin has risen and try to do your differential diagnosis based on that. But let's not go too deeply into that right now, and let's talk about jaundice a little more broadly in this particular video. So because of the problem in the liver in this case, we are going to have increased amount of ALT and AST. So it depends on what sort of damage has been caused to the liver. In some cases, usually we see ALT more than AST in viral hepatitis. In case of alcoholic hepatitis, it is very characteristic that AST rises much more than ALT. The ratio will be about 2:1. And ALP is normal because so far we are talking about a problem with the liver. And there's nothing wrong with the gallbladder in this case. And the clinical presentation will again depend on the sort of damage that the liver has seen. For example, if it is viral, they're going to have constitutional symptoms like fever, myalgias, arthralgias, and so on and so forth. If it's alcoholic hepatitis, we can see symptoms like if that has gotten very serious, we can see palmar erythema, spider angiomas, gynecomastia. All these getting very severe could lead to portal hypertension, leading to variceal formations. Again, that's a whole another video. So clinical presentation, here we're going to also write down variable, right? Because now you have an idea of why it can be variable. Let us go to posthepatic jaundice. Posthepatic jaundice means there is some issue after the liver. So where is our conjugated bile going after the liver? It's going to the gallbladder, right? So the gallbladder, these are the right and left hepatic ducts forming the common hepatic duct, joining the cystic duct, forming the common bile duct. Both of them going along with the pancreatic duct into the intestine through the ampulla of Vater. In this case, we have our RBC dying normally, bilirubin coming out of the macrophage, being transported by albumin, being conjugated. So we have a normal amount of conjugated bilirubin in this case. But in obstructive jaundice, which is another name for posthepatic jaundice, there is some sort of obstruction after the liver. That means there could be some stone in the gallbladder that is not releasing the bile properly into the duodenum, or some inflammation here, or there could be some tumor here, or the pancreatic head could develop a tumor blocking the ampulla of Vater. So in this case, we have our conjugated bilirubin forming, but it is not able to reach the intestine. So if it is not able to reach the intestine, will the bacteria in the intestine be able to form urobilinogen? No, there's not going to be any urobilinogen formed because there's not any conjugated bilirubin transport itself into the intestine. If there is no urobilinogen, will there be enterohepatic cycling? No. Is there going to be stercobilinogen formed? There is no stercobilinogen formed. So will our feces be in the brown characteristic color? No, they're going to be pale because this pigment that is imparting the brown color is not going to be there. Next, will there be urobilin in the urine? No. But the urine is still going to be dark. Can you guess why? Because there is so much conjugated bilirubin in the liver right here, and it is not able to take its normal paths. It is going to leak into the plasma, it is going to leak into the circulation. So from the circulation it is going to reach the kidney, and we are going to see conjugated bilirubin in the kidney. So again, whenever you see bilirubin in the urine, not urobilin, bilirubin is in the urine, implies that it is conjugated bilirubin. So it could likely be an obstructive pathology. So again, what are the conditions that could cause an obstructive jaundice? Obstructive or posthepatic jaundice. We could have cholecystitis, cholelithiasis, pancreatic carcinoma. What happens to the serum bilirubin in this case? Bilirubin on the whole is going to increase, right? Because there's just accumulation of bilirubin. It is not being excreted, but a lot of it is being accumulated. Then, what about conjugated bilirubin? This is going to increase. What about unconjugated bilirubin? This is going to be normal because the conjugation process is happening normally because the liver is fine. What about the urine bilirubin? It is going to be present and there can be an increased quantity of it. What about the serum urobilin? This is going to be absent, obviously. What about the urine and stool? We have discussed that we are going to get pale or acholic, that's another name, stool, and we are going to get dark urine. These are very characteristic features of obstructive jaundice. And in our clinical presentation, again, it's going to depend on the condition that we see. If there is pancreatic carcinoma, we're going to see weight loss and some endocrinal and exocrinal pathologies. And if there's something like cholecystitis, they're going to have a fatty fertile female presenting with intermittent spasmodic pain every time she eats. So again, this is also variable depending on the disease presentation. What about the enzymes? At least in the early stages, the liver is normal, and it is likely that if there is a gallbladder pathology, it could be very clear with an increased ALP level. Eventually, because of this blockage, that could affect the liver and that could affect the ALT and AST enzymes, but initially and more importantly, your ALP is going to be raised, and we're just going to write down AST and ALT to be normal in this case. And the thing is, ALP is an enzyme that is seen in the bile duct epithelium, yes, but also this could rise if there is a problem in the bones as well, because this is an enzyme that is possessed by the bone cells also. So to make sure that it is a bile duct pathology, we have to check the enzyme called GGT. So if you have a rise in both GGT and ALP, you can pretty much localize it to gallbladder disease. Now again, these are the clinical presentations that we spoke about particularly, but you have to realize that because this is jaundice, you are definitely going to see yellowish discoloration of, most importantly, sclera, and then there is nails, and then eventually the skin could also show the discoloration if there's a very high amount of hyperbilirubinemia. So I hope it has been made very clear to you in the video how jaundice occurs and why it presents the way it does in the laboratory findings and in the clinical presentations. I know that I've not gone into much depth of all the conditions, but I do hope that this has provided a really nice overview for you to brush up on in depth later on. I found this table online on Dr. Vijay Markala's website. Complete credit to him. This is just to help you as a reference. This is a table of the causes in a better way from Robbins' 9th edition. Lastly, thank you so much for watching. This is my first video, so forgive me for any mistakes and hopefully I'll keep getting better. If it did help you, please do let me know by liking, sharing, and leaving a comment down below. And also let me know what topic you'd want me to cover next. Thank you very much.